My name is Dr. Samuel Matthew Olomo, and today we shall be doing a presentation on clinical evaluation and recording of vision. This recording or presentation is ideal for clinical students in optometry. They are ideal for medical residents in ophthalmology. They are also ideal for clinicians who want to broaden their knowledge, as well as the general public who may want to have an insight on how vision is recorded. Our outline today is introduction, integral aspects of vision, clinical evaluation of vision, standard methods of assessing, measuring, and recording visual function vis-a-vis visual acuity, mathematical basis of visual acuity, interconversion of visual acuity of different optotypes, conclusion and references. Introduction. The importance of vision, that is, the ability to see, cannot be overemphasized in our daily lives. This is because vision is an indispensable tool in almost every. A good quality of life is about 75 to 80% predicative on a prognosis of good vision. The ancient know this and therefore posited that the eyes are the windows to the outside world. Based on this, it soon became necessary for eye care practitioners to define as well as quantitatively vision itself. The best or the quest for this definition of vision has seen through various challenges, modifications, and remodifications to compensate for areas of deficiencies in older concepts, also in new advances and complexities in differential diagnostic tests and procedures in eye care practice, as well as their repeatability. Other challenges such as consensus and internationally accepted standard became imperative. Today, as eye care providers, clinical evaluation of vision, both qualitatively, as we have said before, and the recording of same is in an internationally accepted standard for future references is and has become an inseparable part of our daily routine practices. Sequel to the foregoing, therefore, the need to examine in retrospect and understand the various means of evaluating vision and the recording of same became invaluable. Now, we're going to talk about aspects of vision. Remember, we're talking about clinical evaluation and recording of vision. So what aspects of vision are we talking about? Now, there are two integral aspects of vision. We have the visual function and the functional vision. These two terms describe vision in two totally different ways. The term is not interchangeable, and when they occur, they mean two different things. Visual function describes visual abilities with respect to the physiological states of the apparatus of vision. Okay, when we say apparatus of vision, we're talking about the cornea, the crystalline lens, as well as the retina. Okay, as well as the impact the disease state of these apparatus have on vision. So when there is a disease state on the cornea, on the crystalline lens, as well as in the retina, what impact of these have on your vision is what is recorded as visual function. And this is what is routinely assessed in the clinic as visual acuity, visual field. So anytime you go to the clinic or you as an eye care provider wants to assess a patient's vision routinely and you ask the patient to read on the screen or some test optotypes. So what you are recording is visual acuity, and that visual acuity is actually a measure of what visual function. Now, the impact of the disease states are called impairments. The next one is the functional vision. On the other hand, refers to abilities the status of visual function has on the activities of daily living of the individual. What that means is the practical vision. So first is the visual function, how much you can see, what you can see, and then functional vision means this vision that you have, how does it impact on your daily living? That is functional vision. Now, the total absence or restriction of these abilities resulting from faulty status of functional vision is termed handicap or disability. So when your visual function is so impaired by disease state or such that it impacts significantly on your daily activity, that is what is termed handicap or disability. Clinical evaluation of vision. A patient's vision is assessed on one or more combination of the four oculovisual systems. Remember, our topic again is clinical evaluation and recording of vision. When we want to evaluate vision, it is evaluated based on four oculovisual systems, and these are visual, binocular, refractive, and ocular health. Cross-check all of these, you find out that there's a common denominator for all of these, and that is the case history and the visual acuity. And of course, our presentation today will be focusing more on the visual acuity. Tests of assessment of visual function includes visual acuity, contrast sensitivity, color vision, visual field, and disability glare. In this presentation, visual acuity will be discussed in detail, including the mathematical basis, the physiological basis, and the interconversion and interpretation. Visual acuity is a measure of a patient's ability to resolve fine details. It is actually a measure of foveal vision, or in the best available parafoveal area. However, since it is easily measured and it is an effective screening tool, it is the most commonly used measurement of visual function made by clinicians. Visual acuity in general is used to assess the adequacy of a spectacle correction and as a key indicator of ocular health. Visual acuity is evaluated in four areas. One, we have the ability to recognize the smallest letter, which is what is really done in most clinics. Then two, ability to discriminate spatial orientation. This is done especially for statistical purposes. Then we have the third one, ability to resolve clump lines or letters into distinct components. And four, ability to distinguish between same letters of slightness disparity. This is what we call stereopsis. A standard visual acuity involves the ability to detect a gap subtending an angle of 1 minute of arc, the ability to resolve the smallest letter size with macular angular subtendence of 5 minutes of arc at a distance of 6 meters. Now, these are the standard definitions of visual acuity. Okay, unfortunately, these definitions are a misnomer and almost entirely arbitrary. Why so? Now we have to examine that in detail. Now let's first of all take a look at this chart, this table here. This table is a normal age matched visual acuity data for various notations from Elliott et al. In 1995, who compared the visual acuity of patients with normal visual acuity for different age brackets. It has been experimentally determined that the letter height of the 6-6 acuity line on the Snellen chart subtend an angle of 5 minutes of arc on the retina surface. The height of the letters on the 6-6 acuity line is approximately 8.75 millimeters. We will discuss this in detail, how this is arrived at. Whereas the vertical distance between the two letters on the same 6-6 acuity line subtends an angle of 1 minute of arc. The standard experimental distance at which this angular subtends hold true is 6 meters. Here, number 60 multiplied by 100. So this is what we have, 100 divided by 60, which will give us 16.67 millimeters. So the focal point from the corneal plane will be 16.67 millimeters. Okay, now if you look at the distance from the corneal plane up to the point where the object is standing is 6,000 millimeters, which is 6 meters, and that's equivalent to 20 feet. And as we said before, that the height of the object that will subtend an angle of 5 minutes of arc at the foveal plane will have to be 8.725 millimeter high. Okay, and then the angular subtendence here, which is R, at which this holds true, will have to be calculated using the SOHCAHTOA principle. It's a mathematical principle. And as you know, the SOHCAHTOA principle, where sine is equal to opposite over hypotenuse, and cosine is adjacent over hypotenuse, and tan is equal to opposite over adjacent. And from our diagram, we are looking for R. So if we make our R the subject, it will mean we have to use the tan, which is opposite over adjacent. And when we make this, it becomes, this is the formula, it becomes 2 tan inverse 8725 divided by 2 divided by 6,000, and this will give us approximately 5 minutes of arc. Okay, this is how we arrived at the angular subtends, okay, at the macular plane. This is the angular subtends at which the 8.725 will subtend 1 minute of arc at the macular plane. So the next slide here, using this angular subtends of 5 minutes of arc as our standard reference point for the measurement of visual acuity, projections for the other test distances and their corresponding letter heights can be made. This is what gives rise to the denominator fractions in routine recording of visual acuity with Snelling charts. That is, at what testing distance x and letter height y will the letters in a VA line subtend 5 minutes of arc at the macular plane. To answer this question, just like we solved before, the minimum angle of resolution, which is MAR, of that VA line must first of all be obtained, and this can be gotten by the reciprocal of the VA line. For instance, if the VA line is 6/36, then the minimum angle of resolution will have to be the inverse of that, which is 36 divided by 6, and this will give us the equal to 6. The letter height y therefore will be equal to 6. Now we have to substitute in our previous formula. Remember the one we got before through SOHCAHTOA, where we say R will be equal to 2 tan x and then these values. Okay, so now let's put that formula. So having gotten our MAR to be 6, then our letter height y will be equal to 6 multiplied by 6 tan 5, which equal to 52.36 millimeter high. Using the letter height of 660 Acuity line, for instance, the minimum angle of resolution will be equal to 10. For instance, the expected letter heights for varied testing distances is presented below. Okay, here is the 6 meters line from the cornea plane. This is the cornea plane, and the object is placed 6 meters away from the cornea plane, and the height of the object that must subtend 5 minutes of arc, okay, at the macular plane, or subtend 1 minute of arc at the macular plane, will have to be 87 millimeters high. Okay, then at 4 meters testing distance, what will be the object height at which this principle holds true? It will have to be 58 millimeters high, and at 3 meters it has to be 44 millimeters, and so on and so forth. At 1 meters it has to be 40.5 millimeter high. So you can see we can actually vary the testing distances and then still get the same results. The height of these letters will subtend the same angles of 5 minutes of arc. At each testing distance, the formula y is equal to MAR x times q applies, where y is the linear height of the specific acuity line, MAR is the reciprocal of the VA line, x is the tested distance, and q is the assumed retinal angular subtends of the acuity line in degrees. And of course, we already have a basis, which is 5 minutes of arc, and then x is the testing distance, which is 6 meters. And if you want to vary the testing distance, you can also substitute any number for x just for you to get the acuity line y. It must be emphasized that near visual acuity is actually a misnomer. Why? This is because in primary eye care examinations, near visual acuity is rarely measured, as it is unusual for threshold limits to be reached clinically. Most reading charts are truncated at the smallest print sizes. Many patients could read sentences of smaller than this if given the chance, so that a threshold is not measured. For this reason, therefore, near vision adequacy is a more appropriate description of the measurement than near visual acuity. Now, conversion of VA of different optotypes. There are 5 main types of notations used to measure near visual acuity. These are the Jaeger system, the equivalent Snelling notation, the Logman notation, the M-scale, and the endpoints. Cards using the Jaeger notation should be thrown away, as there is no standardization of what J1 or J5 etc. means, and different charts can also give totally different sizes of prints with the same J value. The equivalent Snelling notation, on the other hand, is a confusing notation, especially when near VAs are not measured at the standard 40 centimeters. Now, for distance, for instance, what does 6/6 near VA at 20 centimeters mean? In addition, near visual adequacy should indicate what patients can see at their own near walking distance, not an arbitrary standard of 40 centimeters. Walking distances for reading in patients with normal vision ranges from 25 to 50 centimeters, just like we said before. So there is a range, because there are people with shorter arms, there are people with longer arms. So an arbitrary 40 centimeters is not ideal for all patients. The near logman charts have all the advantages of their distance chart compatriot. However, these are minimal, given that what is being measured is near vision adequacy rather than near vision acuity. And the metric notation. The 1M notation letter acuity is the unit of near VA measurement in which the height of the lowercase letter x subtends 5 minutes of arc at a testing distance of 1 meter. The standard newsprint size is 1M print, that is for lowercase, and is equivalent to 8 points, and 1.5M prints for uppercase. Now, a 1M print or 1M letter X is equal to 1.45 millimeter high. The L notation print uses the Times New Roman font and is the standard text print used in English-speaking countries like Nigeria and other Anglophone countries. It is based on the point size used by printers and word processing packages on modern computers, where 1 point is equivalent to 1/72 inch. And if you do the conversion, that should be 0.353 millimeters. This is a typical example of the N notation charts. And again, these are the equivalent VAs if you want to convert from one testing scale to another, from the N scale to the M unit, the equivalent Snelling chart, and their common usages. And in conclusion, clinical evaluation of visual function, one of the integral aspects of vision via visual acuity, is no doubt one of the commonest routine clinical procedures by eye care practitioners, and perhaps one of the most important parameters or indicators of good vision. For instance, your spectacle prescription, can be measured mostly on the basis of your visual acuity. So you can see why visual acuity is very, very important. It is therefore important to understand the elementary basis as well as the intricacies involved in the overall computation of visual acuities, as this will help the eye care practitioners, the medical student, the optometry student, the registrar who is doing residency in ophthalmology, and the general public in manipulation of this data under different testing variables, which this presentation has explicitly mirrored. I want to thank you for this presentation, and if you do have any specific questions, you can please email us or send us messages, and we will be so glad to respond to them. You can also give us some reviews and also follow us on our channel. Thank you very much. Have a nice day.